Next topic that we are going to take up is rickettsial diseases. Of course, there's a big overlap with microbiology, but I'm not impinging on the arena of microbiology. But rickettsial disease is a public health problem because of the way it spreads and because of the morbidity it causes. It's not very killing disease. The case fatality rates would be less than 2%, but still it's a public health problem because whenever it occurs, it will occur like boom. It's like explosive outbreaks. So rickettsial diseases, rickettsia, if I talk about rickettsia, these are non-spore gram-negative, non-spore forming, pleomorphic. That means different morphology could be there. It could be in cocci, it could be bacilli, it could be thread-shaped, whatever. Pleomorphic, obligate intracellular organisms. That means I want to tell you that these bacilli are always found within the cells. That means I want to tell you that the culture cannot be done on a simple agar plates or other cultures. It has to use a tissue culture. So obligate intracellular, polymorphic, different forms are there. It's a non-spore, it's a gram-negative organism. If you look at your favorite chart, you must have seen this chart. It's a WHO given combination of many diseases, many rickettsia at a single place. You must have seen this a lot of times, but let me just ease this out for you. If I want to ease this out for you, I would like to tell you 4 important things that you just look at this diagram. 4 things out of this whole table. Of course, in microbiology, you must have done it lot times more and much in detail. So I'm just telling you a very brief salient features which you need to remember from an examiner point of view if you look at this table again. This table tells you that there are some spotted fevers and there are typhus fevers or there are some other things. Which are more common in India? First MCQ. Which is more common in India? In India, we have 4 rickettsia which are prevalent as a public health problem. The first is endemic typhus. Endemic typhus, also called as a murine typhus. Second is a scrub typhus. Third is a Q fever. And last is a Indian tick typhus. Indian tick typhus. I don't have space, so I've just written ITT. ITT stands for Indian tick typhus. So I'm repeating what all I have said over here. First MCQ for you to remember is, which are the prevalent rickettsia in India? The prevalent rickettsia in India are endemic typhus, scrub typhus, Q fever, and Indian tick typhus. The epidemic typhus, many people just have a thought that maybe epidemic typhus is there in India. In India, we don't have too much of epidemic typhus. Why? Because it's more important in Latin America. Next, MCQ number 2. So I told you I'll tell you 4 MCQs. MCQ number 2. MCQ number 2, you need to remember somehow that which disease causes which organism. Which organism causes which disease. Third point is, if you just look at this vector, can you see the arthropod vector on the screen? If you can see the arthropod vector on the screen, can you see all the vectors? Tick, mite, tick, louse, flea, mite, nun, louse, tick. There is only one disease which is a flea-borne disease. Which is the only flea-borne disease? MCQ over here, which is the only flea-borne disease is a epidemic. It's a endemic typhus or a murine typhus is the only flea-borne disease. So first MCQ, second MCQ from the vectors. Second, you can see that tick, mite, louse, everything is there in all the vectors except one vector. Can you see that there is no vector for which disease? No vector for Q fever. There is no vector for Q fever. So that is your MCQ number 3. First MCQ is, please remember which are the common rickettsia in India. Second MCQ I told you is that you need to remember the causative organisms and the rickettsia. Third MCQ is Q fever without a vector and flea is only one with murine typhus. Last point, if you talk about the reservoir, can you see the reservoir over here? If you see the reservoir over here, all are animal reservoirs, dog, rodent, mice, dogs, except one. Which one is that? That is a trench fever or a Quintana disease. So we have a trench fever, and also in some cases in epidemic typhus, in some cases we may see human reservoir, but predominantly if they ask you one answer, you should be marking trench fever as having a human reservoir. So these are 4 things I have told you. So let me just write for you to remember that most common rickettsia in India. You need to remember that is a scrub typhus, that is the murine typhus, Indian tick typhus, and we also have a Q fever. Second, I told you that flea is the only vector for murine typhus, and I told you that there is a no vector for Q fever. Third, please remember which organism causes which disease. You need to remember this from the table that you have seen before. And last is 4th point, I would like you to remember that humans are a reservoir for one answer, that is a trench fever. Trench fever. A reservoir is a human. Reservoir is a human in trench fever and also in some cases of epidemic typhus. In certain situations of epidemic typhus, otherwise your best answer is a trench fever. So that's all that you need to know from this particular table. Let's go into this table and let's have a word about more on the rickettsial disease. So first thing, what is a scrub typhus? MCQs on scrub typhus. Salient features of scrub typhus. Scrub typhus, what is the most common zones? The most common area which is affected is Southeast Asia, China. Southeast Asia comprises of India, Bangladesh, and Russia. For scrub typhus, please remember that this list is not exhaustive. It is not the only list, right? So it's the other areas are also there, but these are the most common areas for scrub typhus. The causative organism, the agent or the causative organism is a rickettsia tsutsugamushi. Tsutsugamushi. The mode of transmission is a trombiculid mite. Remember, scrub typhus is by mite. I don't know how many times they will ask you, but they will keep on asking you till the time you don't remember that scrub typhus is caused by a trombiculid mite. So if you talk about the life cycle or the mode of transmission in detail, if you talk about the life cycle, the mite is there and it gives the infection to the rats. Later on, the rat give back the infection to the mite. So that means there is a mite-rat-mite cycle. So sometimes in this whole game of mite-rat-mite cycle, so there is a mite, there is a rat, there is a rat. So mite-rat-mite, they keep on playing with scrub typhus. Sometimes in this whole game of mite-rat-mite, the infection, the mite may sometimes give the infection to the man. The humans may be bitten by a mite. So in case the human is bitten by this mite, it may lead to a scrub typhus. The incubation period of scrub typhus is 10 to 14 days. Incubation period is 10 to 14 days. If you talk about the clinical features, the clinical feature is fever with rash. Rash will develop on 5th to 7th day. The rash will develop on 5th to 7th day of fever. 5th to 7th day of fever. And there is a classical Eschar formation. It is, what is Eschar formation? It is a black spot near the bite of the mite. Okay, bite of the mite, there is a Eschar formation somewhere on the forearm. It could be on the legs, it could be on the body. So wherever the mite has bitten. Otherwise, there is also generalized, other features are generalized lymphadenopathy, and there could be lymph node swellings and all these things. So, but the typical is 5th to 7th day, there is a rash, typical rash in this rickettsial disease with the Eschar formation. This is almost pathognomonic of scrub typhus. What is the investigation? How do we investigate scrub typhus? Is a Weil-Felix reaction. Weil-Felix reaction. And what is the treatment? Tetracycline, doxycycline. Tetracycline, doxycycline is the treatment. So important point for you to remember is the Tsutsugamoshi. Next is if you talk about the murine typhus. If you talk about the murine typhus is predominantly, that is the endemic typhus, murine typhus or the endemic typhus. It is predominantly present in many areas. Usually we say worldwide prevalence, but it is predominant in Southeast Asia, not East, it is in South Asia. It is predominant in Western Pacific areas and in eastern part of Asia. So I'm not saying a southeast, that Vietnam, Indonesia column. It is in the southern part of Asia and it is in the eastern part of Asia and it is in the Western Pacific, that is some of the Hawaiian Islands or Western Pacific area, which are more towards the Japan. So in those areas you have these endemicities for murine typhus or the endemic typhus. The Rickettsia causative organism. The organism is Rickettsia typhi. If you talk about the mode of transmission, the reservoir is the rats. And what is the vector which causes? The vector which causes is a flea. You remember, flea-borne disease is only one, that is a endemic typhus. The vector is a flea. So usually the flea is there and the flea will give the infection to the rats. The rat may give back this infection to the flea. So there is a rat cycle which goes on. Sometimes the flea will be biting a human also. So in those cases, this infection may spread to the humans. This disease in certain situations, in some louse may be transmitting it. But if they ask you one question, mark flea. But if they give you two options, that is flea or louse, so you need to mark both the things. But louse is not the most common vector for transmitting. The endemic typhus is only a flea-borne disease. If you talk about the incubation period, next is, let us talk about the incubation period. The incubation period of endemic typhus is roughly around 1 week to 14 days. 1 week to 2 weeks. Clinical features, nothing very special. It causes a fever with rash. Endemic typhus is essentially a mild disease and it may be self-limiting. How do we diagnose endemic typhus? It is by serology. Wheel-Felix reaction with Proteus OX19 antigen. This is the Wheel-Felix reaction. This is the diagnostic modality. And how do we treat it? Same answer, doxycycline, tetracycline. Treatment of choice for murine typhus or endemic typhus is doxycycline. Next I would like to talk about is Q fever. So all the diseases which are prevalent in India, actually I am discussing those diseases which are a public health problem. Next is we are going to talk about Q fever. Q fever knows no boundaries. Q fever is predominant in many parts of the world, wherever there is more predominant rural areas, agricultural areas. Agricultural areas or rural areas. The causative organism is a Coxiella burnetii. And what is the mode of transmission? The mode of transmission is through a direct contact. It is through a direct contact from human to human transmission can occur. It is by airborne. That is inhalation, or it could be by ingestion also. So direct contact, human to human transmission by ingestion or by inhalation. Please remember, I would like to emphasize again, there is no arthropod vector. For Q fever. Q fever is a very special disease. I'll tell you later on that Q fever is the only disease which does not have a rash, and Q fever is the only disease which does not have a vector. A rickettsial disease, right? If you talk about the incubation period is 2 to 3 weeks. What are the classical clinical features? What are the clinical features of this Q fever? The clinical features of Q fever is fever, with influenza-like picture. Influenza-like picture, that means there will be coryza and cold. Influenza-like picture. It may lead to a coryza and cold, and in some complication, it may even land up into a pneumonia-like picture with decline in the forced expiratory rates and respiratory distress. So Q fever is not very cool or simple or mild disease. It may exacerbate. The complications may also include secondary infections or respiratory distress. We have already written it. How do we treat it? Treatment is by doxycycline. Investigation is by serology only. The serology is investigation which is done for Q fever. Right? Next is a few questions about Indian tick typhus. So the fourth point, we have discussed about murine typhus, we discussed about Q fever, we discussed about scrub typhus, and we are going to discuss about the Indian tick typhus. Indian tick typhus is predominant in, of course, the name is Indian tick typhus, so it is predominant in South Asia and Southeast Asia. The causative organism is Rickettsia connori, or also called as Rickettsia rickettsii. The vector which transmit is ticks. So both hard tick and soft tick may transmit, but if they ask you one answer, hard tick is the best answer. What happens is that there is a dog and which gives the infection to the tick. The tick gives back the infection to the dog. So there is a tick-dog-tick cycle. Now somehow, unfortunately, the tick may also transmit the infection to the man. Now the man may also give the infection again back to the tick. The man may again give the infection back to the tick. So there is a dog-tick-tock cycle, tick-man-tick cycle. So now this is a full cycle of the game. So now this whole disease is pretty, it's again the prevalence of the disease, the seroprevalence of the disease will stay in the community because of the reservoir. So what is the reservoir? The reservoir is a dog. Reservoir of Indian tick typhus is a dog. The incubation period is roughly around 2 to 7 days. So it's a pretty fast acting disease. The clinical features, if you talk, there is a fever, high-grade fever in Indian tick typhus. There is a pretty high-grade fever and with rash. The rash characteristically will develop on 3rd to 4th day. The rash will develop on 3rd to 4th day, and how do we treat it? Treatment is by simple answer, doxycycline, tetracycline is the drug of choice. For all the rickettsial disease, treatment is one answer, that is tetracycline. So that's all about most of your questions on rickettsia. I would like to tell you that Q fever is a special disease. Q fever is a special disease. There is no vector and Q fever has no rash. All rickettsia will present with rash except Q fever. All rickettsia will have a vector except Q fever. I would also like to talk to you, since I'm saying so much of rashes all the time. Let me just take this opportunity to talk to you about what diseases, what type of rashes you find. So this is a general topic discussion right now, not pertaining only to rickettsia. It may include other communicable diseases. Rash producing diseases. So it could be a part of your infectious disease epidemiology as well. But anyways, let me take it now, right now. First is meningococcal rash. So there is a characteristic meningococcal rash. This meningococcal rash is characteristic pink color rash. It is a maculopapular rash. And it is MCQ, tender to touch. Tender to touch. If you talk about rubella, the rash in rubella is associated, rash is associated with lymphadenopathy. There is associated cervical and cervical lymphadenopathy, especially cervical lymphadenopathy. Lymphadenopathy. pathy. Third is, if you talk about the rash from rubeola, the rash will characteristically start from face. It goes towards the trunk and it moves towards the arms, right? But on the other hand, if you talk about the rash from epidemic typhus, it starts from a very typical position, starts from axillary folds. And it spares palm and soles. If you talk about the rash from scrub typhus, the rash from scrub typhus is essentially, it's also maculopapular rash, but the rash from scrub typhus is essentially associated, just now we discussed, with the Eschar formation, plus there could be lymphadenopathies, lymph node swelling as also with the scrub typhus. If you talk about the rash from rickettsial pox, it is a characteristic vesicular rash. So chicken pox, vesicular rash, rickettsial pox, again a vesicular, that's the reason we call it as a pox disease. It's a rickettsial pox, that is a vesicular rash. Sometimes students also ask me about Rocky Mountain spotted fever. The Rocky Mountain spotted fever, so that's usually not present in India because the Rocky Mountains are there in the northern part of America. Rocky Mountain spotted fever. The rash in this starts from extremities, starts from the limbs, extremities. They spread to the trunk and then go to the palms and soles. So they start from extremities, go to the trunk and may trunk or the face also, and then they use or extend to the palms and soles also. Palms and soles are also affected in the Rocky Mountain spotted fever. So that's one very important, one more feature about Rocky Mountain spotted fever is it is associated usually plus or minus, I'm not saying 100%, it's not a pathognomonic, but if it is almost sure shot, it is vasculitis. Vasculitis is a characteristic feature of not found in any rickettsial disease, any disease. Vasculitis with rash is Rocky Mountain spotted fever. Eschar with rash is scrub typhus. Axillary fold is epidemic typhus. These are some rashes which are very frequently asked to you, and these are the things which may help you in your exam. So with that, I would like to close off this topic on rickettsial disease. Thank you so much.